Hello, my name is Harriel Deshommes, and I am a fourth-year medical student at the Florida State University College of Medicine. And today I'll be presenting on the preoperative evaluation of pubocervical fascia with endovaginal ultrasonography and correlation during robotic sacrocervicopexy. I have no disclosures. Genital organ prolapse is associated with muscular and neurologic injury after childbirth, which affects the apical and anterior support of pelvic organs. One of the many fascial attachments affected after childbirth is the pubocervical fascia. This is a fibromuscular coat of the vaginal epithelium that does not look like a distinct fascial layer histologically, but can be identified clinically. We believe that the identification of pubocervical fascia injury prior to surgery is essential in the evaluation of pelvic organ prolapse patients. A retrospective analysis was done in 110 women with symptomatic pelvic organ prolapse, and each participant underwent an initial preoperative pelvic floor ultrasonography evaluation using perineal floor ultrasonography and endovaginal ultrasonography during Valsalva. We identified areas of pubocervical fascial weakness based on the presence of any hypoechoic areas between the bladder floor and the anterior vaginal wall. Several measurements were performed on the main hypoechoic area, including the hypoechoic area distance to the pubic symphysis, the hypoechoic area distance to the bladder neck, and the hypoechoic area distance to the posterior bladder wall. We then correlated the pubocervical fascial weakness with its respective POP-Q stage. Ultimately, we were able to use our initial measurements to compare our office findings with the findings noted during surgery. Out of the 110 women in this study, 15 were excluded due to previous pelvic organ prolapse repair or missing ultrasonography data, leaving us with 95 complete data sets available for analysis. 80 patients were treated with a conservative approach, and 15 desired to undergo robotic sacrocervicopexy with pubocervical fascial reconstruction. Median follow-up in the 110 women with complete data was about 8 months. As expected, the mean age in the conservative group was higher. Demographics were similar in both groups, and on pelvic exams, significant prolapse of the anterior, posterior, and apical compartment were defined as stage 2 or higher using the POP-Q staging system. In both groups, most of the patients have stage 3 pelvic organ prolapse. For those that chose to undergo surgery, the anterior compartment evaluation was done using endovaginal ultrasound preoperatively and intraoperatively. The 4 measurements previously discussed were performed on the hypoechoic defect. No significant difference was found between the two groups. This may demonstrate that the preoperative evaluation with ultrasonography is as equally as effective as intraoperative endovaginal ultrasonography evaluation. We then did a correlations analysis and found a significant association of a mean hypoechoic defect measuring 1.9 centimeters with POP-Q stage 3. This validates that anterior vaginal wall weakness is associated with hypoechoic defects. A significant correlation was also found between preoperative endovaginal ultrasound, mean hypoechoic defect measuring 1.9 centimeters, and 10 plications during surgery. Therefore, preoperative ultrasound evaluation is necessary in predicting the anterior dissection, as well as the number of pubocervical fascia plications done during robotic sacrocervicopexy. When we performed between 7 to 12 plications, the length of the anterior vaginal mesh decreased to a 4 and a 6. On the left, we have a sagittal view of an endovaginal ultrasound image. We can see the bowel on the posterior aspect of the bladder, an emptied bladder, and the pubic symphysis on the right. We have outlined the hypoechoic defect in this patient, which measures about 2 centimeters in length. This is a patient with pelvic organ prolapse, apical and anterior stage 3. In this clip, the patient is performing a Valsalva maneuver. The increasing abdominal pressure is demonstrated by the bowel moving forward, which in turn pushes the bladder forward as well. It's important to note that during Valsalva, that vaginal probe is being pushed out by the prolapse. As you can see within the hypoechoic defect, there is compression of the pubocervical fascia, which is also moving forward. We can then see how the hypoechoic defect decreases in thickness and moves forward and down, which is consistent with the point of weakness in the assessment of pelvic organ prolapse. For comparison, the clip on the right is of a patient without pelvic organ prolapse performing the Valsalva maneuver. Measures of hypoechoic areas obtained by endovaginal ultrasound imaging between the anterior vaginal wall and bladder floor are associated with POP-Q stage 3 at the anterior compartment, supporting our theory that pubocervical fascia injuries may present as hypoechoic areas during endovaginal ultrasound. This seems to correlate with the number of plications that we do during robotic surgery and may prevent anterior compartment failures after robotic sacrocervicopexy. And this may open new applications for endovaginal ultrasonography in the evaluation and treatment of pelvic organ prolapse. Thank you for watching.